Good afternoon, and welcome to this installment of the Galen Healthcare Solutions webcast series. Today we've taken a slightly different format and put the viewer in the driver's seat by having our whole presentation based off questions submitted by our audience. Before we get started, I want to address a couple housekeeping items. First, all phone lines are muted to prevent any interruptions during the presentation. If you have a question at any point during the presentation, please ask it by using the Q&A function within the WebEx. There's a button in the top right of your WebEx screen that you can click to open the Q&A panel. Enter your questions into the text box at the bottom of the panel and make sure it is directed to all panelists. We will answer any questions at the end of the presentation. If we don't get a chance to answer your question today, we'll follow up with an answer within a few days. All unanswered questions will be posted in Q&A format on our blog and wiki. To give you a little background on our organization, Galen Healthcare Solutions is a healthcare-focused services and solutions company. One of the key factors to our success is our company culture. Our expertise is both wide and deep, and our employees regularly make themselves available to each other in order to ensure the highest quality of services to our clients. For over a decade, Galen has built a solid reputation of providing high-quality services to health systems, hospitals, and physician practices. We provide world-class professional and technical services to healthcare organizations that interoperate, aggregate, convert, harvest, and optimize clinical patient information within your multi-vendor system portfolio, including PM systems, your EMR, and also HIE. We deliver a suite of fully integrated products that enhance, automate, and simplify the access and use of clinical patient data within those systems to improve cost efficiency and quality outcomes. Your presenters today are Tyler Swatchy and Julia Snabb. Tyler is a principal consultant here at Galen with over 12 years of experience in the healthcare IT industry. His extensive experience in data migrations across multiple vendor platforms, along with his planning, strategy, and integration architecture background, make him an ideal candidate for answering the most intricate data migration questions. Julia is a managing consultant at Galen. She oversees all our data migration projects and has over 14 years of experience in the health IT field. She was a former Allscripts project manager and is Epic Ambulatory and IP Orders certified. With Julia's oversight on a plethora of our data migration projects, she knows how to lead projects to success and answer your questions on how to do so. Now here she is to start us off with our first round of questions.
Thanks, Julie, and welcome everyone to today's presentation. We have presented many migration webcasts in the past. However, this one is unique in that today's presentation is built around questions submitted by audience members during the registration process. Before we get into answering some of your questions, we thought it was important to share a little bit about our migration experience and methodology for those of you who may not be familiar with it. After that, we'll jump into answering the questions that were submitted for today's webcast. The three questions that we'll be answering are: how to efficiently limit scope, how to overcome challenges when migrating multiple source systems, and Galen's recommendation for migrating reports, results, and documents. Even if you submitted questions prior to the webcast, we encourage everyone during the presentation to submit any follow-up questions that you may have, and we'll try to answer those at the end of the presentation. Please enter your questions in the Q&A section of the WebEx, and as we mentioned before, for any questions we are unable to answer, we will follow up with you via an email. When an organization has made the decision to transition to a new EHR, a lot of thought and consideration has to be invested in how to handle the current system and clinical data. There are two main things to consider: the legal medical record versus the clinical data to support continuity of care. Every organization has legal requirements that must be followed when decommissioning the system. It is important to understand what the laws are in terms of what data needs to be kept and for how long. Some organizations may decide to switch their licenses to read-only. However, if they're decommissioning multiple systems, they will still have to maintain multiple systems and data is stored in multiple places. There may be better cost alternative methods out there to meet the legal requirements than switching over to read-only. We at Galen have an archive solution in place called Vital Center Online, and we have worked with many clients to archive their data to meet the legal requirements. This solution supports a full decommission of the legacy systems and allows data from multiple systems to be accessed in one central location. The second important item to consider is that some of the clinical data will need to be referenced to continue caring for patients. Your providers will not want to spend valuable time rebuilding their charts in the new system. There are many items to consider when determining what is actually needed to support continuity of care. However, since you won't need to bring everything over, it allows the organization to pick and choose the most valuable clinical data to migrate to the new system. To try and simplify these two main points, when we refer to the legal aspects of keeping the data from the retiring system, we use the term archive. When we refer to ensuring the proper amount of clinical data is in the new EHR to support continuity of care, we use the term migrate. This presentation will be answering specific questions on how organizations decide what data should be migrated to support continuity of care. However, if you are interested in learning more about archival strategy or more about our solution, Vital Center Online, please let us know and we'll put you in touch with the right resources who can answer your questions. Over the past few years, Galen has performed over 220 data migrations from various EHR systems in both the ambulatory and inpatient environments to 4 of the largest EHRs, Epic, Cerner, Allscripts, and Meditech. We have worked with over 25 different legacy systems such as Allscripts TouchWorks, Allscripts Professional, GE Centricity, ARIA, SRS, etc. We continue to gain experience working with new vendors each year. Currently, we have over 30 active migration projects in all different stages. The most common clinical data elements that we have been asked to migrate are centered around 10 main elements. They are the ones in this PowerPoint followed by an asterisk, and they are patient demographics, encounters or visits, notes, results, scanned images, vital signs, allergies, immunizations, medications, and problems. However, we have been asked to migrate other clinical data such as PCPs, patients' preferred pharmacies, future appointments, future and standing orders, inpatient charges. Also, if you have a data element in mind and are unsure if it can be migrated, let us know the source system, so where the data is coming from, the target system, where the data is going to, and the data element in question. We can follow up with you and let you know the likelihood on how that data can be migrated. Here's a common migration timeline. This timeline is a 9-month implementation with 2 months of support. Many factors go into determining the project timeline, and we have performed migrations in as little as 3 to 4 months, and some projects have spanned almost 2 years. Generally, we see a lot of migrations falling into this 9-month implementation timeline. Every migration project will follow our 8-phase methodology. The first phase of the project is gaining access to all of the systems that will either be extracting data from or loading data into. Then, as part of the second phase, our technical team will work on writing the extract scripts to extract the data from the source system and will create mapping workbooks. Also during this time, the team will evaluate the data based on our experience from past migrations. We look for specific scenarios that need to be addressed to prevent issues in later phases of the project. The third phase is the data mapping phase. During this phase, our clinical analysts will use the mapping workbooks to map the legacy system entries to the appropriate dictionary entries in the target system. This is where it's beneficial to have resources who are familiar with both systems, as it generally isn't a one-to-one mapping. A great example of this is from an Allscripts TouchWorks to Epic migration regarding mapping document types. In Allscripts, the standard established new patient document type will be mapped to a progress note in Epic. If someone wasn't familiar with the workflow in Epic, they may recommend that a new note type get created in Epic to match exactly what is in TouchWorks. However, the downside of creating a new document type is that the migrated data would display differently in chart review than if the note was created directly in Epic. End users would have to look at two different document types to find the specific note that they are looking for. Phases 4 through 6 represent our testing and validation phases. We start off with small-scale validation. During small-scale validation, we recommend testing a very small subset, usually around 25 patients, to ensure scope is applied correctly in the extract scripts. We want to ensure that we are extracting only what is in scope. Large-scale validation, we recommend increasing the patient population and by getting end users involved in the validation as they are most familiar with the data. During large-scale validation, not only do we double-check to make sure that we are extracting only what is in scope, but we also go through workflow testing to make sure that when we migrate the data to the new system, that the data looks and acts how it should. The next phase is full-scale validation. Full-scale validation is a dress rehearsal for production. We use this time to perform the full data extracts and loads. This allows us to get real-time estimates, so we have enough time to plan when we need to kick off the extracts. Also, when we load the data, we'll get a better idea of the production errors that we may encounter. This allows a project team to work and resolve as many errors prior to the real production loads. Phase 7 represents the end user go live and when the data is loaded into the production system. And the last phase of our project is the support phase. I want everything is something we hear a lot. How do you decide what to migrate when providers want everything? Providers and staff have worked diligently for years entering data in their EHR and don't want to lose all of that hard work when they transition to a new system. Identifying the data elements that are truly required to maintain continuity of care is the best plan, as this will limit the overall effort, reducing costs and allowing for a shorter timeline. The process of determining the project scope varies from one organization to the next. But from our experiences, we have found that organizations that include decision makers from each of the areas affected by the migration, all the way from providers and CMIOs to CIOs and project managers, have had the most success. While getting everyone to agree on scope will be tough, it is extremely important first step in the data migration process. A data migration will never meet the legal requirements for archiving data. There is specific criteria that is set at the state and federal levels that organizations must meet when decommissioning systems. Even if you decide to migrate all data, a data migration cannot include the audit history and versioning that is required to decommission a system. A data migration only migrates the latest version of a clinical item. Our stance on data migrations is to migrate the least amount of data that is needed to provide patient care. There are potential risks when migrating too much data. One is that it may make finding the data more challenging if end users have to sift through a high volume of data to find what they're looking for. The best example of this is around notes. We recommend that a note migration is limited to key notes that will be referenced by end users to direct care. We ask the project team members to spend time upfront evaluating each note type and determining if the contents of the notes will be referenced in the future to treat patients. Our general recommendation is to migrate visit notes, procedure notes, H&Ps, operative notes, discharge summaries, etc. The notes that we do not recommend to migrate are the administrative type notes. For example, no-shows, return to work letters, telephone notes, etc. The other risk of migrating everything is migrating data without evaluating the system limitations that will dictate the usability of the data in the target system. Chances are, if end users have expectations that migrated data will act a certain way, they'll be frustrated if their expectations don't match the reality. For example, many times we are asked to migrate open tasks. End users want to be able to work their tasks in the legacy system one day, and then jump to the new system the next day and have their outstanding tasks be available to them. To date, we have not migrated open tasks in a discrete manner that supports the transition due to system limitations. The reality of migrating tasks generally results in a report that is created that lists all open tasks. It does not support migrating discrete tasks that populate ones in basket. It is important to recognize that just because the data can be extracted or migrated, the format or the usability should come into play to determine if it's part of scope or not. Providers say that they want all lab results in their EHR migrated to the new system. It's important to understand if there are any current workflows or other migrations that may duplicate information in the new EHR. We have experience where we need to filter clinical data from our extracts as that information may already be or may soon be in the new system, and we need to prevent duplicate information from displaying. From our experience, it is easy to prevent that duplication if we know what criteria we need to follow to filter out the duplicate data. Here is an example of patient-level elements that any client may evaluate when determining scope for their data migration project. The first column lists the clinical element that the client is considering to migrate. The second column is where the data will be pulled from. The third is the method in which the data will be loaded into the target system. The fourth column is what we determined to be best for end users based on what Galen knows to be true about the EHR systems and experience from past migration projects, followed by our overall recommendation. I'll walk you through some scenarios around a couple of these data elements. However, it's important to understand that these scenarios and table are generalized for the purpose of this presentation. The first is around administered and recorded immunizations. Immunization data typically resides in your EHR as well as in the state registry. As part of your new system implementation, you may be configuring the inbound interface to load immunization history into your EHR. If this is the case, you have two options to provide the source of immunization history as part of the migration. The best solution is to determine which source has the most accurate and complete data. If the answer is that both have them, then cost comes into play. If you're already building the interface to support the registry, then it will be more cost-effective to use that method to populate immunization history versus migrating it from your source EHR. The second is around completed medications. When asking the end users why they want to migrate completed medications, they've expressed that they want to be able to see the medication, but more importantly, they want the ability to easily renew a past medication. We took the time to explain to the providers that migrating completed medications as part of a CCD will show the history of the medication, but they will not have the ability to easily renew that medication as completed medications display as read-only on a report. Once they heard that they would not be able to renew a completed medication, it wasn't as important to include past medications in scope just for the purpose of seeing the history. The third example is around past medical history. For one of our clients, the target system could only consume the problem history as part of a CCD. However, the clinical data is displayed as part of a read-only report. There wasn't any functionality that allowed end users to reconcile the data. In talking with the client, they felt as though the data was critical to have, but because the data was view-only, they needed to establish an abstraction workflow to get that data discretely in the patient's chart. Due to that extra work effort, the client satisfaction around that clinical data element was neutral. So, how do you decide what is included in scope? There are many things to consider when trying to determine what scope is needed to support continuity of care. What is too much data and what is too little? When evaluating scope, we recommend asking yourself these 5 questions. The first is it needed to treat patients? Since the migration will not support the legal needs to store all of your data, this is your opportunity to only bring over what is necessary. Do you need to see a full history of all of your lab results? What tests will you order now to treat the patient? What results are important to see the historic trend to treat your patients? Or what is needed for health maintenance alerts and quality reporting? The second is, where is the most reliable place to get the data? The example I used previously was around the immunization registry. However, another thing to consider is if the two source systems provide different data. A common example that we see is around lab results. Lab results are in the EHR may have an annotation that the provider made after reviewing the results and talking with the patient. If you determine to use the lab vendor as a source for the migration, this result annotation will not be moved to the target system because it only lives in the EHR. That difference in data may be significant enough to decide that the source of the data should be from the EHR versus the lab system. Questions 3 and 4 are setting the stage if migrating certain data elements will meet the expectations of your end users. Question 3 is, can it be extracted from the source system discretely or non-discretely? This may be difficult to answer prior to kicking off the actual data migration. However, maybe your end users are aware of certain workflows that will prevent the data from being extracted discretely. Common examples that we see are around diabetic foot and eye exams. Many times these are documented within a visit note in a non-discrete manner, which makes it difficult to migrate these results discretely that is needed to support meaningful use. The fourth question is, can the target system consume the data so that it is usable to end users? This is another question that may be difficult to answer unless you're familiar with your target system. However, resources at Galen or from the vendor can help answer this. It may be important for your organization to migrate past surgical history. Depending on your target system, some vendors support migrating that data discretely, other vendors may support it non-discretely, and some vendors cannot support consuming those data elements at all. If the data cannot be migrated or can only be migrated non-discretely, you may need a manual abstraction process to get that data in discretely in order to meet end users' expectations. And the final question is the cost worth it? This question in itself can be its own webcast. However, very high level, if the complexity of migrating the data will cost significantly more than the benefit your end users will gain from it, it isn't worth it. If you're currently working to evaluate scope for an upcoming data migration, we encourage you to reach out to us if you have any questions. We do offer assessment services to help organizations answer these questions.
My name is Tyler Swatchy, and I'll be answering the next couple of questions that we received. The first one is in regards to migrating multiple systems. What is the biggest challenge with migrating from multiple source EHRs? And subsequently, what can be done to overcome this challenge? As Julia mentioned earlier, we've engaged in many migration projects for our clients over the years. While many of these projects were typically a migration of a single legacy EHR, we've had a fair share of larger migrations that included multiple systems. Those systems may not only be EHRs, but they could be ancillary systems too, such as lab information systems, document management systems, or any combination of any of those types of systems. The biggest issue or concern with migrating data from multiple legacy systems is that the same piece of clinical data, whether it's an allergy, a medication, or a document, or whatever it may reside in more than one of the source systems. For example, a specific patient allergy may be recorded in multiple source EHRs. Obviously, when this piece of data, or allergy in this case, is migrated into the new EHR, we only want one instance of that item to display. This will help reduce clutter in the chart and make the process of finding relevant data easier for the users of the new EHR. This issue can happen with single source system migrations, but it becomes much more common when migrating multiple systems simultaneously. There are a few things that can be done to reduce or hopefully eliminate the data duplication in these types of scenarios. The first thing that can be done is on the extraction side of the ETL process. And as Julie alluded to earlier, it would be to filter data out of some of the systems. If there are ways to identify the duplicated data across the systems, then we would recommend extracting the specific type of data from only one of the systems and filter it out from the others. For example, if a lab system is feeding results to multiple EHRs, then the data should be extracted from only one of the EHRs and filtered out of the others. An even better strategy in this scenario might be to not even extract the results from any of the lab EHRs, from any of the EHRs for the specific lab, but instead reload the results into the new EHR directly from the lab system. There are other things to consider when taking this approach, but this is a process we have used successfully in the past. We found that this strategy of filtering data during the extraction phase in order to reduce duplication works really well for documents and results, especially if these pieces of data are being fed to the legacy EHR by interfaces, in which case there are generally attributes associated with the documents and results that allows them to be easily identified as potential duplicates across different systems. For some data sets, there is no way to filter the data during extraction. Any clinical data that is manually added to the chart, such as allergies, medications, or problems, generally cannot be identified as a duplicate during the data extraction process. For these data sets, we recommend aggregating the data from each of the source systems into a single repository where it can be analyzed and duplicates can be identified. Our technical services team finds that using a SQL database is the best place to perform this type of analysis. Using our own set of tools, we'll extract the data from each of the source systems and analyze the aggregated data to find the potential duplicates on a patient's chart before it's even loaded into the new EHR. The results of the analysis are even stronger and more accurate if the legacy EHRs use common code sets or terminologies, which most systems do now anyway. For example, many systems use RxNorm to codify medications or assign CBX codes to their immunizations. Some data sets use multiple code sets, such as problems where a system may assign ICD-9, ICD-10, CPT, and SNOMED codes to each of the problems. If we can incorporate these code sets into our duplication analysis, the results are even more precise and the users will be even happier with the results of the data migration. Another option for reducing data duplication is to leverage the CCD import functionality in the new EHR. Many EHRs allow for the import of data, primarily PAMI data, problems, allergies, medications, and immunizations, via CCD, as opposed to an HL7 interface or discrete file import. CCD data usually needs to be reconciled by the user of the new HR before it becomes part of the patient's chart. This process has a couple of benefits in regards to reducing data duplication. First, some EHRs will perform duplicate checking upon importing and parsing the CCD. Each data element in the CCD is checked against what already exists in the patient's chart and what is already pending reconciliation from other CCDs that have been imported. This duplicate checking typically relies on a common code set, again, as we discussed previously, or some form of name matching, but it can be very strong. The second benefit is that the CCD import process usually requires the user to reconcile the data in the CCD. With an HL7 or discrete file import, the data immediately becomes part of the patient's chart, whereas with the CCD import, the data typically must be reviewed by a user and each item needs to be brought into the chart. While this may sound time-consuming for the users, this is a common method used in data migrations, and one of its benefits is that it helps reduce the duplication of PAMI data in the patient's chart. And the final bullet on here is just a reminder that whatever method is selected for reducing data duplication across the systems, be sure to validate the process thoroughly to confirm that the process is working correctly and the results that you're seeing in the new EHR are behaving as they're intended. Now, given everything that I mentioned, there's still going to be some situations in which duplication cannot be avoided, or the process of eliminating duplication compromises the quality of the migration. For example, if one legacy EHR contains discrete lab results and another EHR that's also in scope for data migration in the same project has the same results, but they've been scanned in, it will likely be difficult to filter the scans in order to prevent duplication of the results. Identifying the exact scans that contain those lab results will be nearly impossible, given the way that scans are typically stored in an EHR. In order to truly prevent the duplication of the results in this scenario, the results from one of the legacy EHRs would have to be omitted from the migration, which would likely compromise the quality of the final product or of the migration. So in summary, as you can see, migrating data from multiple EHRs definitely adds a layer of complexity to a migration project and raises a new set of concerns for the project team, primarily around the duplication of data. The ability to eliminate data duplication can depend on the specific EHRs and how they are used, but there are some strategies that can help resolve the issue and can be applied to any migration project with multiple source systems. Galen has developed a data migration methodology, as Julia mentioned earlier, and a custom migration platform called Galen ETL, which has been the subject of previous webcasts. And it really allows for any of these methods to be used and deployed in a migration project. The next question we wanted to address was around our recommendation for migrating results, documents, and reports from the legacy system. We received a couple similar questions to this and thought now would be a good time to address this question. We typically see results and documents included in a data migration as these data sets contain valuable information for not only treating patients and bridging the continuity of patient care gap, but also for supporting quality measure reporting and other reporting initiatives. For results data to be its most useful, it really needs to be migrated discretely. This will allow for the reporting and flow sheeting activities that are generally required of results. Therefore, we recommend migrating results via HL7 or some other discrete method that's supported by the new EHR. There are a couple ways to generate the HL7 messages. The most common method that we use is to extract the discrete results data from the legacy EHR, and then leveraging our Galen ETL conversion platform, we'll transform it into HL7 messages that can be loaded directly into the new EHR. This method really allows us to heavily customize the results migration to match the needs of the project. We can limit results to only a certain number of years, for example, the last 2 years of lab results, or reduce the number of results to only certain types of results or panels. For example, only those results that are most important when treating patients or those that are needed to support reporting initiatives. We can also limit results to only the last set of results for certain types of panels or certain types of orders. The extent to which we customize the results extraction filtering is really driven by the client. And it goes back to the point that Julia made earlier about migrating with a purpose. Only migrate what needs to be migrated. Don't migrate unnecessary data. Another method we have used for generating HL7 result messages is to have the lab information system resend all of the HL7 message, as I mentioned earlier. This method doesn't easily allow for customizations, but depending on the details of the project, it can be a quick and easy way to migrate a large volume of results. This process is also dependent on the functionality of the LIS, so be sure to check that those systems can support the retransmission of historical result messages. For imaging results, we recommend migrating the textual reports at a minimum. Most of the time, the imaging report is enough to treat patients and bridge that continuity of care. But if your organization decides that the images associated with the reports are also required in the new EHR, then we would recommend migrating the links to those PACS systems in order to preserve the link and allow your users the ability to access those PACS images in the new EHR. For documents, there are really two categories of data, notes and scans. Notes refer to the documentation generated in a legacy EHR, generally at the time of a visit. Sometimes this data is generated directly in the EHR using custom tools or features within the EHR, but it can also come in more simply as a transcription. Either way, notes are a valuable piece of data because they contain details about many of the other data sets, allowing users to get lots of information from a single piece of data. We generally see some form of notes migrated during the migration projects, but as Julia discussed earlier, we really recommend that it's limited to those with meaningful content. Scanned images are generally low on the priority list for migration, but depending on the workflows within your organization and the level of integration or lack of integration with other systems, scans may contain some valuable information in them, in which case certain types of scans may be candidates for migration. The major drawback with scans is that the data is tied up in a non-discrete format, and unfortunately there's no way to change that during a data migration. For any reports that have been built in the legacy EHR, we don't really recommend migrating the specific reports. Instead, we would recommend identifying the data that is being used to build that report and discreetly migrate that data and rebuild the report in the new EHR. For example, if there was a report that looked for patients with certain types of active problems and displayed their most recent instance of a specific result value, then we recommend migrating the active problems discreetly and the results that are necessary to build the report. We migrate that data into the new EHR and then rebuild the report off of that data. Again, finally, as I mentioned earlier, thoroughly validating the migration of all of these items during the course of the project will be necessary to ensure that they are being migrated in a way that satisfies the requirements of your organization. Validation is one of the key components to our data migration strategy, and it plays a crucial role in the success of any migration project. So we place a strong emphasis on testing and validation to make sure the migration that we deliver meets or exceeds the expectations of our clients.
Thank you both for that informative and insightful presentation. It looks like there was a few questions submitted during the presentation, so we'll go over those at this time. It looks like during your portion, Julia, there was 2 questions submitted, so these will be directed towards you. The first question is, in the example where you said you were not able to migrate tasks, what system limited it? Was it your process or was it one of the systems? The second question is there ever a system that is too small to migrate?
Thanks, Julie. So to repeat the question is surrounding the example that I provided when talking about migrating open tasks. And if you guys remember, we had said that we had not yet migrated tasks in a discrete manner. And so the question really focuses around why have we not been able to migrate tasks discretely? And from our experience, when we've been tried to migrate tasks, it's because the target system, the system that we've been loading the data into, just not support the consumption of open tasks in a discrete manner. So the question is there ever a system that is too small to migrate data And the answer is yes. So we do have general guidelines in place based on our experience, how many patients, what volume tends to the cost and effort be worth the actual outcome. Maybe it's more cost effective to manually abstract those patients instead of putting the effort and cost towards a data migration. Generally, we say the cutoff of patients is usually under 10,000 patients, but there are other factors that come into play. But if you are looking at a system that might only have a couple thousand patients, it might be more cost effective to have a manual abstraction process in place compared to a data migration.
Thanks, Julia. It looks like there was 2 other questions that were submitted during Tyler's portion, so these will be directed towards him. The first question is, how does your approach differ for different EHR vendors? And the second question is, you mentioned CCD and HL7 a lot during your presentation, but what if these formats aren't supported by the new EHR? Are there other options that you've worked with?
Thanks, Julie. Those are really good questions. For the first question, I'd say that our overall approach to the migration remains pretty much the same, regardless of the legacy EHR or the EHR that we're migrating to, as long as the 2 projects have similar scopes. We're going to have a similar project plan with many of the same steps, including a fair amount of testing and validation. So overall, they'd be very similar. One of the key differences from the technical side is the manner in which we may need to obtain the legacy data. Our preferred method is direct access to the legacy EHR, which allows us to easily extract it into our Galen ETL platform. However, this isn't always attainable for numerous reasons. So we may need to get creative and use other methods for getting that data. But ultimately, the data needs to be loaded into Galen ETL, into our platform. A recent example of this where we had to get creative was for a system that would only supply us with CCDs. Now, the client tried loading the CCD directly into the new EHR without any manipulation of it, but they weren't happy with the results. Many of the critical components of the CCD were missing, or specific data elements were missing from the CCD. So our solution was to enhance our Galen ETL platform and allow us to parse the legacy CCD into discrete data elements. Then we'd fill in the blanks where data was missing with using some mapping logic, and we would then rebuild a stronger and more complete CCD using a standard plugin or a standard feature of our conversion platform. So, and then deliver that CCD and load that CCD into the new EHR, which the customer was much happier with. We did something similar recently for another project where the legacy system could only provide the PAMI data in HL7 format. Again, we tacked it the same way or a similar way. We enhanced Galen ETL, allowing us to parse the HL7 into discrete data, where we could then apply mappings and then build a CCD from that HL7 data. And then the CCD would be loaded into the target, or excuse me, the go forward EHR. As for the second question, we discussed earlier that a lot of our migrations are to Epic, which uses CCD and HL7 interfaces as a primary method for migrating data. However, we've also worked with other vendors that use different methods for importing data. Some have required flat files with discrete data. Some have required working directly with the backend databases and making calls in the database to import data. Some have required us to even call specific APIs that they've made available for importing data. we built support for any of these into our Galen ETL platform, and we continue to build support for new methods as we work with new systems or faced with new challenges. So if you have a system that you're migrating to that may not fit what we've discussed today, it's still worthwhile to reach out and talk about the formats in which the data needs to be transformed to work with your new EHR.
Thanks, Tyler. The answers to any questions that we weren't able to get to today will be posted on our blog and wiki for your convenience. Thank you very much for attending today's webcast. If any additional questions arise later on, you can contact us through our website or email education@galenhealthcare.com. We hope you have an enjoyable rest of your day.